Hi everybody, welcome back. Lovely to see you all. I hope you've had a productive break and managed to ask some questions. First, a quick apology. We are going to put this recorded session up on YouTube as quickly as we can today because unfortunately there's been a bit of a technical problem and several people haven't been able to access the Zoom link, for which apologies. Hopefully they will get access to this really quickly. We have tried to see if we can remedy the problem and it doesn't look like we can. It's a bit beyond our control. So apologies on that one. Thank you for registering your interest regardless. And so next up, we've got our patient perspective, and this is a gentleman who I've known for a very long time, and I have to confess, wasn't expecting him to agree to do this session. Joe is a published author. He is, you can go look at his books if you want to and buy them. Affiliate links are available, joking. And he is going to talk to us from his perspective. So thank you, Joe. Joe Thomas.
Yeah, I think it's a not bad place to start, actually. Why would I agree to do this? Because I hate talking about migraine, and I always have done. And the starting point for me, actually, was to think about why I hate talking about migraine and why I don't want to listen to what people have to tell me about migraine, and why I don't want to sit in a room for 3 days, 4 days, or just today for Patients' Day to learn about migraine. And it struck me that that was a reasonable place to start thinking about my experience as a patient, and then to think about the chronology of how long I have suffered, if that's the right word, or have coped with migraine. When I think about it, part of the reason why I don't like to talk about migraine is a character flaw, perhaps. I don't like to be told what to do, particularly. I'm not that keen on unsolicited advice. And so generally I kind of not really interested in what other people have got to tell me about things. I can pretty much like to believe that I can figure it out for myself. Migraine, however, I've never been able to figure out. And it struck me, again, sort of considering this question, why do I hate talking about it? It's a unique experience that we have if you have migraine. And as much as possible, although there are obvious overlaps of experience or commonalities, it has struck me, talking to other people with migraine, talking to doctors, not talking to other people as much as possible, but it has always struck me that these are we have very, very individual conditions, is that the right word? Conditions, afflictions. And so when someone has the temerity to tell us what the reason might be or how we should deal with our own problem, I've always found that difficult. I've always wanted to push that away. I'd rather not have someone else's opinion and instead just sort of try and cope and manage the situation myself. So that's that was the sort of starting point, which is why I agreed to speak for a few minutes, because I think that if we start from that position that this is our thing to cope with, something that is unique, something that is apparently, again, the word incurable may not be the right thing to use, but something that needs to be managed rather than solved. And it has taken me, I think, 35 years, more or less, to reach a point where I'm comfortable with understanding that this is something to be managed, not solved. My experience started, I think my first migraine, I think I was 11 years old, and I've been playing snooker at a friend's house for about 2 days straight. And I suddenly couldn't see properly. And it was a sort of worrying symptom, nothing that I'd experienced before. And then the headache came from there. And in my teenage years, they were sort of spread out, I think, between... And actually, the pattern of that youthful, exuberant opening of getting migraine as an 11-year-old and then as a teenager has pretty much settled throughout my entire life. And that's something I'm always interested to hear. I've pretty much had the same experience for 35 years, which is between 3 to 5 weeks, every 3 to 5 weeks on average across a year, a migraine that is debilitating in the sense of I can't see properly out of one of my eyes and need to create space, and then for myself, and then a headache. The difference is, perhaps in the latter years, has been that I can now, it's great, that, as I said, that light's really good, it's sort of like a classic trigger. Oh, that's better, just stand over here. now I see why you were standing on this side. Yes. Where was I? I was talking about the fact that it's been the same. The difference has been, I think, that as I've got a bit older and more experience with migraine, and it is a sense of you becoming experienced with your own experience or beginning to understand your own experience, is that what I can do now is work out, once I've got the migraine, go, oh yeah, I was about to get a migraine and I did nothing about it. And that's something that wasn't the case 20 years ago. What's the perspective? As I said, I was thinking about this the last few days, the last week or so, when I agreed to do this or to talk, as informally as I can. And it's about what is there that one can offer in a situation where it is very much unique. And it struck me that we could talk about not migraine, because I can't tell you what's worked or what's not. I'm not going to go through the medications because I'm not allowed to. And also, frankly, I can't remember, because the only thing that's ever worked is paracetamol and ibuprofen, and then an alcoholic drink a little bit later afterwards. And fast food also actually quite contributes to the recovery. But what it struck me was interesting is that perhaps one thing that is not talked about is not the migraine itself and not the experience of having to deal with the migraine, but the experience of having to live with the fact that there's always a good chance that you might get a migraine. That's the thing that I struggle with more than anything else. The pain isn't like it used to be, and I gather that's something that happens as you get older, particularly as a man, I gather. I'm not 100% sure on that. I'm not really interested in trying out different drugs because nothing ever worked. My migraines aren't too debilitating, particularly. I've done a job interview with one and got the job. I've done book events when I can't see properly and have sparkled. So that it hasn't really affected my career or my life in those moments. But what it has done is that every day, I'm always thinking about, is there a chance I might get a migraine? And that could be on a very, very simple level, like today. Coming here, what if I got a migraine? That would be annoying. Maybe not, maybe it would be perfect. Or on very special occasions, when you're always thinking about, what can I do to stop myself getting a migraine? And you don't really know. What should I do? How can I best prepare myself? And that's something that I'd be interested in thinking about. How do you cope, or how do you manage the fact that you're always worried about something? The key, the more debilitating thing and again, I realise that on the hierarchy or the taxonomy, whatever the right word is, of migraine sufferers, I'm quite low down. I don't have to lie down for 2 days in a dark room. I can function. I had one on Friday. I was at work, I had a walk, drank a bottle of water, no alcohol at work, ate some salmon that was in front of me, and then shook it off and did the thing I had to do next. And I've always been able to deal with that, and it's not pleasant, but you can cope with it. But it strikes me that the more interesting thing sometimes, from my perspective, is how do you deal with the fact that you might get one, and the tension, the kind of the fear that creates. So yeah, I'm just sharing that really. That's the thing that I struggle with most, and I wonder if that's something that where do we go to cope with that expectation of potentially getting a migraine, and how can that potentially ruin, as I said, a special occasion. In terms of I mentioned before about the experience and getting to know your experience or understanding your experience. I've never quite worked out what the triggers might be, I suppose. I did the thing that the GP told me when I was 19 and didn't drink red wine or eat cheese, Marmite, chocolate, that's right. Well, that was a wasted 2 years, wasn't it? I've tried to make up for that since, but that didn't make any difference. I lived in Brazil for 10 years, and the climate there was obviously quite different. I was in Sao Paulo, and the intensity of the heat. And I had a kind of cluster of migraines at one point when I was there. In about 4 or 5 weeks, I had a lot, like a dozen, like much more than the sort of worrying level. Went to the hospital. They got insurance, of course, there. So I went to a hospital, was given tests, and a doctor gave me a preventative medication. And all I did was put on weight because that was one of the side effects. That didn't help. The it took me some time to understand that there could be more than one reason that you're getting migraine. People I've spoken to have had the kind of miracle moment. Oh, I'm allergic to peanuts, for example. That's it, no more migraine. I think for the majority of people, I imagine that that's not the case. It's figuring out that there may be one of a half dozen things that can provoke that attack. My thing now is feeling not right, something feeling off, irritable, tired, thinking about the fact of remembering a previous and then not acting on it. And what does acting on it look like? I suppose it means drinking water, eating something, I'm not sure. But there's always that frustration. But at the same time, when the attack happens and you've been feeling like that, and I have the, I think it's classical migraine, which is the flashing lights on either side, flashing element. And one of the things that leads me again back to this sense of managing experience or understanding the experience is that I have simultaneously, when it happens, a feeling of great frustration and anger and great relief, i.e., why has this happened to me now? And thank God that's happened now, because it's something seems to be, some sort of equilibrium seems to be solved physically, or I'm not sure what the right word again is in terms of the cognitive element. So the journey continues, and I think it's 35 years now, 36 years of having migraine or having migraines. I find it difficult to describe myself as someone who has migraine, and yet probably 12 times a year I do, and have done for 30 odd years, which is, well, the maths is not my strong point, but it's quite a high number, quite a lot of hours that you feel have been wasted. And I guess that's one thing that I have thought about more recently, is that if those hours are spent lying in a dark room fuming, they probably are wasted. But if you either decide to, because I physically can, and I'm sure that's not the case for many of you, but if you can push on and do the thing that you've got to do, put it to one side, use it as some kind of spur, that's something I've done. The other thing is that when I do get the opportunity to lie in a dark room, which is rare, but if I do try and enjoy that and think of it as a bit of a break from the rest of the world, as it were, from the rest of what I have to do. I think that in terms of the perspective that I would give is it's impossible for me to talk to anyone else's experience, and that's sort of validating on its own. And secondly, I think that we should be working out how to cope with the fact that we worry about getting a migraine, and how that pretty much is a everyday feeling, even if the actual migraine itself isn't. Thank you for listening.
Thank you, Joe, for that, which was a delight. Phil, would you mind? I've lost Phil. Where's he gone? He's there, getting mic'd up. Excellent. So just a quick reminder, we'll be sending out a survey link at the end. Please fill it in, even if it's just a couple of minutes. And also, if you want to register for the 16th of October for Q&A with Professor Peter Goadsby, which is always insightful and enjoyable. And having said that, I will now hand over to our final presenter of the day, the wonderful Dr. Phil Holland. Welcome to the stage, and thank you.
Thank you. I'll just go get the projector here. I won't stand beside the bright light because my bald forehead will blind most of you in the audience and give you photophobia. So I'll stand over here if that's okay, and keep back so that you can see. I'm a little bit different from the speakers in that I'm a scientist. I can remember once or twice in my life having a headache, so it might seem strange to you that I'm here, but I have 5 sisters, so that might give you a clue to why I have an interest in this topic. One of whom suffers from hemiplegic migraine, actually, where you get motor weakness, and I spoke to a couple of you about that at the start. And a younger sister, who, you say young, but I'm old now, so she's well into her 30s, but she's still the baby of the family, but she gets really debilitating migraine with aura. So it's something that's really close to my heart in that way. I'm going to talk about some of the new treatments. I don't know why there's a little silly razor pointer. We joked that this was happening earlier and it's jumping around, so we try and ignore that little red dot. Maybe it'll go away as we move on. Some of you have been asking us in the break and in the start about the new therapies. And this is just an idea of where we are at the moment. A number of people have been working on these new therapies, so targeting this molecule, calcitonin gene-related peptide, that was first discovered back in the 80s by Professor Peter Goldsby and colleagues. And it's taken a while. There's been a couple of wrong turns along the way, but it's taken a while to really come now to new treatments. I think the most recent GPAN, that's these small molecule drugs that block this receptor here, was approved in England about 4 months ago. And a lot of that's around cost and recovery in the NHS and nice things that David Kernick spoke to and what he's been involved in. But we're in a situation now where we have a number of these antibodies here on the top, and this is the name we know them as, and this is the name that you will know them as on the side here, because that's the trade name, that are approved in the UK, that either target the receptor, so the receptor here, or the actual ligand itself here in green. And what's interesting for me as a scientist is, that's great, we've got these new drugs. I spoke to a young lady there who is what we would call in science a super responder. She said a 75% reduction in her chronic migraine frequency, been on one of these drugs now, one of these antibodies, for I think the past 3 months. So we would class her as a super responder. Not everyone has that same effect. So what we're trying to do now is understand, how can we build on that? How can we make these drugs work in more people? And how can we get new treatments that will work on that? And what I show you here is the fact that there's this other receptor here called, I called it AME1, but it's called amylin. And it's like a cousin of the CGRP receptor. And I'm going to talk you through a little bit about how some work we're doing and others are doing suggests that this might be something that's really relevant in the future. So this is the complicated bit, but essentially just to say that CGRP here is now this little blue circle, and of course it can activate what we call this calcitonin gene-related peptide receptor. That makes sense. But it turns out that it's just as good at activating this other receptor called the amylin-1 receptor. So they have this overlapping biology, shall we say, in the body. And really the theory then being that this can be a novel therapeutic target. So one of the first things that's been looked at this is, think about the context of photophobia, that aversion to light that we spoke about. And some colleagues from around the world did a wonderful study where they looked at this, and they looked at what happens in these models if you give this amylin, or an analogue to that. And what they see here, and I'm just going to take you through this very simply. On the top, this is obviously females, and this is males in the bottom. This is CGRP in blue. So if you're at baseline, you have this response. If you give them CGRP, they become sensitive to the light, the females. They become sensitive to that light and this hypersensitivity. And this amylin activation does the same thing. It makes the female sensitive to this response. But now if you look down here at the bottom, in the males, it doesn't have the same effect. So it seems to have this sex, you've heard about that now, this female and psychoprevalence. It seems to have this sex-specific effect in these photophobic light symptoms. So now we have a related drug to this calcitonin gene-related peptide that's approved in the UK that might be having these effects. Work that's been going on in my laboratory, Tyler, who's in the audience here, has been doing some work before that and has recently come to our laboratory from New Zealand, so it's an international thing we're doing here, brought people across, but funded by the Migraine Trust. Jan Hoffman and Alejandro here were working on this project. So they wanted to ask, well, what happens if you block this receptor in terms of pain response? And if you block this receptor in males, you get this nice response, you get this nice inhibition over time. That's what we would see in science as being a good thing. But what happens when you do it in females? And you heard a bit about this from Gisela, who's speaking from the Leiden Headache Centre. look what happens now. This is females here, black is control, so nothing happens. But if you look at this line here, this is with rising estrogen. So if you've got higher levels of estrogen, remember that's protective in people, you get a nice response like you do in the males. But if you're in a phase that you've got falling estrogen, the drug does nothing, doesn't have an effect. So this starts to mirror what we sometimes see in clinical practice, where during that menstrual-related migraine, some of these drugs are not working so well. And what we're striving to do is understand why and how we can get this line here down here. That's the kind of thing we're working at. That's what the science is doing. So blocking this receptor is not just sex-specific, but it's also cycle-specific. What happens when you give this to patients? So in blue we have CGRP. So some of you lovely patients volunteer to come in and have your migraines triggered. Just imagine that. And we bring you in and we give you a drug, or nitroglycerin or something, and we shove you in a scanner. You go into this little enclosed tube, and it's quite strange because I've had it done myself, and it's so it's very noisy. So if you've got phonophobia, it's probably not the best thing you want to do, or you're claustrophobic. But if you give these people the drug, what happens is that in about EC88 for pramlintide, which is an amylin analog, 97% for CGRP, you get this acute headache, some people call it. I've had it. I don't call it a headache, actually. I just got this kind of bit of pulsatility, felt a little bit like, whoa, what's that? It goes away after 10, 15 minutes. That's fine. That's where we're different. If you're a migraine patient, 1, 2, 3, 4 hours later, this happens. You go into this full-blown migraine-like attack. This is what happens with CGRP. Over half of you will develop that full-blown attack. For pramlintide, this analog, for amylin, it's a little bit lower. But we still know that this drug that we're investigating now in the lab can trigger migraine attacks in patients if we give it to them. So it's something we're really interested in looking into now. So it can trigger these attacks in people with migraine. That's great. We think amylin's going to be a new target. We're really happy it's going along the pipeline, but it's in development. It's going to take a number of years. What do I think is the next thing coming? What will be the next thing you're hearing about in terms of therapy? And for me, I focus on this. This is a very complicated name. We're going to call it PACAP for short, but it's pituitary adenylate cyclase activating polypeptide. And this is a neuronal peptide that's in your hypothalamus. You heard David Kernick speaking excellently about that feeling of balance within the body. And as a scientist, I call that interoception. It's how your hypothalamus, at the centre of your brain, regulates, for example, hot-cold. How it responds to the light. When you walk outside and it's light, that wakes you up. When it's dark, that helps put you to sleep. That's your hypothalamus regulating your sleep-wake cycles. And this PACAP, which is highly expressed here, when you give that to patients now, so blue is the migraine patients, this time black is control, so they're just given a dummy drug. You can see that 90% of people get this acute response, which goes away then, but again, about over half of people get a full-blown migraine attack. And only 10% of the controls, probably because we've brought them in, give them an infusion, take them into hospital, done all these things with them. And this molecule, as I mentioned, I'm just jammed for a second. PACAP can induce these migraine-like attacks in people. And as I said, this is expressed in neurons. Like CGRP, there's PACAP here, and it's in these different pathways that are involved in migraine. And why I think this is really important, because only recently now, a Danish company produced phase 2 clinical trial studies now. So this is, you've got phase 1, which is safety, give it to healthy young people, is it okay? Phase 2 now is looking at dosing and that in patients. And then phase 3 is your big massive trial where you've got to pass at least 2 of those to go then for approval for the drug. This drug is now just this year, end of last year, past phase 2 proof of concept clinical trial for migraine. This is an antibody like the CGRP antibodies. So you would get this injected, and it's hopefully now, if it goes through phase 3, is going to be coming to market in the not too distant future. And it's something that we're very interested in working on in the lab too. So that's in terms of treatment and what's happening there. What else do we know about migraine? What has the lab taught us? What have we done? And this is clinical science as well as basic science that we've been doing. And you guys know this better than me. Migraine's a really complex condition. Last speaker spoke about how he knows an attack's coming on in the trigger because he maybe gets a bit irritable and he gets these responses. These are all part of what we call the premonitory symptom. Patients start to get fatigue. I often tell my students that if you don't notice it, maybe your partner might. Well, that be your boyfriend, girlfriend, wife, husband, because you can see changes and you get that little bit of irritability, that little bit of a change in your behaviour and response. And obviously we have this classical migraine, so about 30% of people will have this aura, these sometimes flashing lights, in some cases hemiplegia, that muscle weakness, into the headache, and then this resolution phase where you just feel absolutely washed out, just completely fatigued. And actually this is the bit we know the least about, so this is probably the next thing we need to focus on. Why does that fatigue last so long? And why is there fatigue here at the start? And as I'll tell you in a minute, I'm glad to say that the Migraine Trust have just funded us, or co-funded us with the Medical Research Council in the UK to study just that for the next 4 years. What are the non-pain symptoms of migraine? So fatigue, arousal difficulties, and all these different features. So we've got these diverse symptoms. It tells me as a scientist that actually, and you've heard this, migraine's not one thing, it's not a single entity. But for me, that means it's really all parts of the brain. It's pain, it's cognition. You've heard of that brain fog. I'm sure a few of you get that cloudiness that you get in your brain. Arousal deficits, so this fatigue, appetite problems, whether it's food might be a trigger that you think that, or whether it's because you're skipping meals or you're just not able to eat. And this is a beautiful study. This is one of my favourite clinical studies. I mentioned that at the scientific meeting. This was a work done by Professor Peter Godesby and Farouk Manier, who's a consultant. Farouk's now out in the Essex area, so if any of you are out in Essex, Farouk's a wonderful consultant out there. And really, this is the thing that put migraine on the map. Not this study, but this kind of work. Because before we had these digital signatures in the brain, migraine was just this hand-waving thing that wasn't a real disease and wasn't taken seriously. But now look where we've come to. We've come to a place where now, between that baseline, so before you're having an attack, when you're starting to feel these early symptoms, I'm getting a little bit irritable, we can now scan and see what areas of the brain, this is the hypothalamus, that little bit that I was talking about that regulates your biology and your homeostasis. And this is the brainstem, periaqueductal grey we call it. This is involved in pain regulation and emotion and sleep-wake cycles. These two areas start to become abnormally active in that very early phase. And what we're going to be doing with the Migraine Trust is looking at, well, how can we actually target that? Because wouldn't it be amazing if instead of treating the pain, what about if you actually tried to treat the attack back here before the pain started and you could stop the pain from starting in the first place? It's a big idea, but it's something that we're going to make a challenge that we go after in the lab. And what's really beautiful about this is this little last line here, is that these activations are not just random. They actually correlate, so they're related to the symptoms that the individual patient is reporting. So we can start to get at the biology of what's happening in every one of your brains during an attack. And then we can take that to the lab and study it, and hopefully make new treatments that act not just to mask the pain, but to actually stop it in its tracks. That's the goal. It's a big one, but we're going to go for it. And one of the things that I've got interested in is this pathway called orexin. I have to say O because some people think I say E, and that sounds completely different. Orexin. It's a different word. For anyone that knows about this molecule, it's the thing that causes narcolepsy when you lose it. It's when these people that just fall asleep randomly and have this instability of sleep-wake regulation. So this is orexin. It's this molecule. It's in the hypothalamus again. It's the only place it's made in the human body within the hypothalamus of the brain. And it's a thing that keeps you awake. So if your orexin pathways are too active, you've probably got some insomnia at night. When you go to sleep, this pathway shuts off. When you wake up, this pathway becomes active. That's one of its main roles. But look what else it does. It regulates wakefulness, feeding, stress and anxiety, nociception, so pain, motivation and reward. So it's one of these master regulators of this, what we call interoception and body homeostasis. So we're really interested in this molecule as, could that be a new therapy for migraine, or something that we could use not just to treat the pain, but to treat the non-pain, the most bothersome symptoms that you feel and report. Here's some early work. So this is allodynia. Clearly I don't suffer from that problem when I brush my hair, because I don't do that anymore. But having 5 sisters, I grew up with many sisters who do brush their hair. And if you look at allodynia as a phenotype, so the perception that something as simple as touch, that's not noxious, but you perceive that as being noxious. If we look at that, and we inhibit this pathway, this orexin pathway, this awake promoting pathway, what we see is that you become much more sensitive to touch. So you respond to that touch in an abnormal way. And if we then sort of reactivate that pathway, so we give exogenous drugs to activate that pathway, we can recover the phenotype. So we can go back to a place where that touch is no longer noxious. And that's a really important thing. So inhibiting this pathway could really help with that allodynia that you might suffer from. But what about fatigue? It's really striking that in a lot of patients, and I don't know your personal experience, and some of you will be sitting saying, I don't get that. Others will be sitting saying, yep, I get that. That fatigue that comes before an attack and after an attack. What is it about that fatigue? So if we look at that now here, so this was just locomotor activity. David Kernick mentioned the wonderful study which was by Faisal, one of our Danish colleagues, that looked at response to a CGRP therapy, and the better you get, the more steps you make. So you can actually use steps, or your steps as an indicator of therapeutic benefit. If we just track movement and you inhibit this pathway, just like the pain response, you get less freely moving ambulatory. So again, this measure of like fatigue, reduced locomotion. And if we recover and activate this pathway, it comes back. And I'm really pleased that in 9 days time, Mignon here is arriving from South Africa to take up a 4-year PhD program with us at King's, part funded by the Migraine Trust, to really look into this in detail. So she's going to be spending the next 4 years of her life really digging into this story and trying to make this so that we can take molecules like this towards the clinic to make things better for all the people suffering with migraine. Right, you've seen this graph before. In fact, at this meeting, this graph was probably shown like, I don't know, maybe probably 20 times, 30 times in different talks. In fact, in this very room, we had over 100 scientific posters. Where you sit now, there was rows and rows of poster boards. And there was over 100 scientific posters from over 750 people from around the world, all talking about these topics. Behind this wall is where we had the big plenary sessions. Great talks about this. This is really striking. It's bad enough if you look at males that things seem to get worse over the life cycle and then they recover a little bit. But look what happens for women. And Gisela touched on this need for female-specific, or maybe not female-specific, it's not the right word, but female-tailored therapies that take into consideration this issue that we have where more women get migraine. And we need to look at that. And here's just a couple of papers. One of these here is by Eloisa, who's from my lab. She's sitting down here, one of the people who spoke to her, where they look at the effect of different therapies. And the evidence, as Gisela showed you, is that the triptans don't seem to be as effective in women. You might have to take an extra dose. You might have to combine it with an NSAID. Remember, I'm not a clinician, so I'm not prescribing that. That's up to them to tell you how to do that. But we've got this evidence that A, the therapies don't work as well, and B, there's this problem that more women have migraine and suffer from it. So what have we been doing in the lab for that? Well, we got interested in this molecule called kisspeptin. It's named after Hershey's Kisses, these American chocolates, for anyone that's interested in it, because it was discovered in 1996 in Hershey. So it's named after this chocolate, which is, most people I think, wrongly presume chocolate's a migraine trigger, so that's probably a good link for migraine. And here's what happens. Here's that same graph. Men now are this sort of greeny, bluey colour here. Women are this kind of colour here. And what you can see is that here's the prevalence, and the dotted line is what kisspeptin is doing within your body. Because kisspeptin is the thing that triggers puberty. It's the master regulator of the onset of puberty in both males and females. But in men it goes up, and then it plateaus. You know, we're very boring men, we just become very static here. In women it goes up, and then it cycles with your cycle. It's the thing that triggers ovulation and the ongoing cycle. So we got very interested in, could this be something like a female-tailored therapeutic target for migraine? Then this study came out, actually. This was 2018, which is quite recent in scientific terms, showing that actually in orofacial pain, this target is upregulated. So if you have orofacial pain, so think of like pain in the jaw region, temporomandibular, this target goes up. That's the black line versus the grey line, and so forth. This is the receptor. So we thought, well, this might be a worthwhile target to look at, and Eloise has been doing this work in a laboratory for the last couple of years now. There's a picture there so that you recognise her and can grab her on the way out if you want to ask her any questions. And again, funded by a one-year fellowship from the Migraine Trust. So I really have to take this opportunity to say that the support of the Migraine Trust, by putting on a meeting like this with experts and for paying for scientists and clinicians to really train and understand these disorders, is invaluable. We couldn't do it without their help. So it's a little bit thing, but this is the cycle here. So there's baseline, and here's proestrus, estrus, metaestrus, driestrus. So looking at different phases across the female cycle. And what we see again is that if you give this molecule kisspeptin, that you can sensitize, but again it's cycle-specific. So it seems to sensitize these migraine pathways in a cycle-specific manner. So again, showing that the female perspective is different to the male perspective with this drug. What's really, really exciting for us is that actually if you block that receptor now, you can see here it really gives a massive response here in inhibiting that pain pathway. So if you block this receptor, it really looks like a really nice and positive target. And we're about to submit a new grant to the Medical Research Council. That's one of the main funders in the UK, that's going in early 2025, to really go after this now as a translational target for migraine that we think has huge potential for women and women who suffer from migraine attacks. That's where I want to stop, because I'm the last speaker of the day and give you time for some questions. I'm happy to answer them. I really want to thank, I say I'm a scientist. I was a scientist once. I used to be in the lab working. More and more, I'm not in the lab doing that. I'm going to these meetings, I'm writing the grants, I'm trying to get funding to do the work. The people who do the work in this picture, but also there's 4 of my wonderful colleagues sitting in the second to front row here. And I just want to thank them for all they do in the lab. I want to thank the Migraine Trust for all the support that we have. It's a really great relationship. I had said I was going to wear my Migraine Trust hoodie for this event, but I forgot to bring it. And I got that because in March, Rob sent me an email that says, oh, remember, we've got this March for Migraine. And I thought, that's a great idea. What is it? And they said, right, we're going to walk 100 miles in March for migraine. For everyone that knows me, I'm not really a walker. I'm a runner. So I said, okay, I'm going to run 100 miles in migraine, 100 miles in March for migraine. And we did that. And for me, that was just a tiny little bit to give back to you guys, because you've been amazing. You've been wonderful for us. And thank you very much for supporting us.
Thank you. Thank you so much. I think that was fascinating. Well, I will not be running 100 miles for March. No,
it wasn't in one go. It was over the month.
Just not at all.
Although I got to the end of the month and I had 15 left to do in the last 2 days, so I had to go out and do a bit of extra work then.
Props to you. Okay, so we have loads of questions. I think it's a really interactive talk. So the first one is asking around whether, and I think it's a bit close to my own heart as well, is there any treatment being developed for aura specifically?
So, been developed specifically for aura? Not really, but I'm not going to name a few, but so please speak to your GP. David might be able to talk about this if you grab him at the end. There are some specific older treatments out there that don't seem to work in migraine, but work well for aura. So they have a different mechanism where they work well for aura. So there are treatments out there. There's a treatment, I'm not telling you to take it, but there's a drug called tonaberset, for example, which works for aura but doesn't work for migraine. But you should speak to your clinician about that.
Kind of, I suppose, just to push you a little further, do you think a kind of acute treatment for aura is ever possible? Is something that can be?
Yeah, so there was a license, not a treatment per se, but there was a neuromodulation device that was available for aura and migraine. It was called transcranial magnetic stimulation, STMS, just a little device you could get, and when you got the aura, you could take a buzz. Unfortunately, the company that had that and had the license for that went bankrupt, but I believe now the license has been bought over by someone else and it's coming back. I don't know if anyone in the room has tried that past time, but that was approved for migraine with aura, the STMS, but it's coming back now. But one of the things, and I'm not an expert in this, but the NHS and costing and NICE and things, they're all set up to evaluate drugs. They're not really set up very well to evaluate a little digital device box that can do something. So there's always implications with costing to get these things approved. But it is licensed. You can get it for aura. Where I think we did the science, actually. I did the science when I was in San Francisco for how that might work. We were the first to show the mechanism by which it might block aura. That was a really nice study. But what I really liked about that one was, again, the potential for, say, women of a childbearing age or women who are breastfeeding. It's not a drug, it's not something that's systemic, it's a local effect, and therefore it had safety implications for that. But again, it's probably going to be a while before it's available again.
Thank you, that's great. I know there's actually been a little talk about this weekend, actually, so it's good to see a question on it, but someone was asking, is there any best time to take a medication? Any kind of when you...
Yeah. So, two iterations of this ago, I think myself and one of my PhD students at the time, Lauren Strother, gave a talk about chronotype and chronotherapy. And that is, so in the UK we would say night owls and morning larks. And I'm kind of a bit of both. I'm okay whatever time of day. But if you're a morning lark, you're much more likely, the evidence suggests you're much more likely to get your attacks in the morning. And if you're a night owl, you're much more likely to get them in the evening. And again, there'll be individuals here who say that's not right. I get them whenever. But at a population level, we've just done a study, and we're just about to publish this study. We've looked at 2.4 million people across the world in a diary study, and we've looked and seen, and the most popular time to get an attack for people is waking up with that attack between 6 and, say, 10 in the morning. Now, what that means, if you think about that triggering work I showed you, if you're waking up with an attack at 6 in the morning, it's probably that attack started before that. 3, 4, 2 in the morning building. And this molecule, calcitonin gene-related peptide that we speak about, these drugs, there's not great studies in migraine patients. That needs to be done really well in terms of the cycle of that. But in healthy males, there's one study that shows that the peak of that molecule in circulating within the body is at about 11 p.m. at night. So really, the science tells me that if you're on something like, say, a GPAN, a small molecule drug, you should be considering taking that in the evening. There's obviously benefits to that. One of them is side effects of some of these drugs are somnolence and fatigue. Well, it would make sense then even to reduce side effect profile to take them before you go to bed. Because if it's once a day, that's okay. And there's evidence, not from migraine, but from things like chemotherapy, for example. The time you take the chemotherapy can have a huge effect on the outcome of that drug, because you minimise the side effects and maximise the positive effects of that drug. What we need to do in migraine is really do those studies. I tried to get money for it. Rob knows this. We were speaking about this. Unfortunately, the response I got at the time was, that's a really wonderful idea, but we've got the drug, so we can just give it to patients. Why bother? And really the problem there is that we bother because those... and say 40, 50% of people respond, we might be able to make it 60 or 70. Or we might be able to take those people that respond and they have a 50% reduction in attacks. We might be able to push that to 60, 70. And it's going to take time to get there, but we're still fighting to get those answers.
Yeah, I think it would be really important research. Someone is pushing you a little bit further. So you said PACAP might be available in the not too distant future. They want you to put some years on it, if possible.
I think that's impossible to do, and the honest answer is because I've been in migraine research now since I started my PhD under Professor Peter Goldsby at Queen Square in London in this is where I need to get correct. 2001, I think. 2001, I think. Yeah, I started my PhD, and I've seen so many molecules, drugs, targets come along and dip away, and for different reasons. Not all because of failure, some because of other reasons. This one's in phase 2 clinical trial, which means it's the furthest along the pipeline in terms of approval. For example, Gisela had on her slide a Ditan. I don't know if any of you saw that. She showed the Ditan. That's already approved, but you can't get it in the UK because they've not applied for a license in the UK. You can get it in the US, you can get it in some European states, but it's not available. It's like a cousin of the triptans. But the advantage of that drug is that it doesn't have blood vessel effects. So the triptans are contraindicated in anyone who's got cerebrovascular. These Ditans aren't, but at the moment there's no license for it in the UK, so you can't get it here. So there are drugs that are even closer if we could get the license. These trials are going to take a number of years to run. You've got to have at least 2 positive trials. Then you've got to apply to the FDA in America or the NICE here and the EHMA. You've got to then apply and get the approval, so how long that takes. The CGRP drugs were available, like as an approved available, long before you could get them on the NHS, because the Migraine Trust fought tirelessly for this. I know they did, along with other patient organisations, to get NICE to actually approve them and allow them to be given on the NHS, because sadly it's not just about when the drug's available, it's about what the cost is, and there's a lot of migraine patients out there who want these therapies. I mean, you know that as well as I do.
Thank you. Yeah, there were a few questions around why I can't get this drug because it's available elsewhere, so thank you for giving a bit of context.
Yeah, it seems, just to touch on that, you may have noticed I'm Scottish. Some of you might have worked that one out. So recently we had a big launch thing down here in London for, I think it was the Rimegepant drug. It was launched a few months ago in England on the NHS, and it was all great news, and it was in the BBC, and we saw one Rob Music on the BBC. You may have seen him. Peter Goes, where other people were on promoting this. That was wonderful. But that had been available in the Scottish pathway for quite some time before that. So even within the UK as a whole, there is still a little bit of a lottery in terms of access to that. But not just access to that, really another linked point, and I'm going to have a plug for BASH here, the British Association for the Study of Headache, and the Migraine Trust. GPs with a special interest in headache, people like David Kernick, who specialise in migraine and take a really strong interest in headache. You know, it's a bit of a lottery if you get access to them, and if you're lucky enough to be close to one of those GPs, do try and get to see them, because they're amazing. They understand the new treatments, the new therapies, and they really can be helpful.
Awesome, thank you. I do have more questions for you, not free yet, but I was just going to pause to see if anyone wanted to ask anything in the audience. No? Perfect. So there's been quite a few questions as well on, and we do hear it on the helpline quite a lot as well, about sort of the impact of COVID on headaches and migraine. Is there any research into that? Will there be any research into that, into looking at the links?
Lots. Yeah. So there's a couple of interesting things. We spoke about timing. Actually, during COVID, and I mentioned this to someone at the back earlier on, during COVID, the global prevalence or incidence of headache occurring, there's a few studies actually showing that it went down a little. And I don't know the reason for that. There's been some studies, but I predict the reason for that is that we weren't forced to constrain to the working pattern that we go against our own biological clocks. If you're not a morning person, but you have to be up and early and into work at a certain time, you're perturbing that natural clock. You're going against your intrinsic biological clock. And it seemed to settle down for people. But in terms of COVID, of course, one of the symptoms of COVID was headache. And we know this is involved in, infection, immune response. And think of it as Gisela showed you with that threshold. And anything in COVID is one of those events that can push that threshold up towards that triggering event. You're closer to that sort of, when I do it in school, when I do it in the lectures to the undergraduate students, I talk about one of those, those little penny machines you put in and they stack up at the end. And everything's stacking up at the end. And if you put another thing in there, which is, say, a COVID-based infection, you're just more likely to tip over the edge and go into that attack. So really, that's the whole thing about lifestyle, about anything you can do to sort of pull that back is going to be advantageous.
Thank you. I'm going to try and squeeze in 2 more questions, if that's okay. I know I haven't been able to get through all of them, so I'm sorry. Do contact the Migraine Trust and we'll be able to help you. But so the first one is, could you tell us a little bit more about why medications and sort of STMS type treatments stop working or people stop responding to them? Is there evidence to suggest why that can be the case?
Yeah, it's a really interesting point. So why do, we know with pharmacologically speaking, and there's better pharmacology students in the audience here than me. I'm a neuroscientist, but there's better pharmacology. You have this thing called tolerance, where, things get, like drugs, then you have to take them at higher doses to have the same response in the receptive field diagram. I had a conversation with somebody earlier, actually, over one of the breaks, and they asked me, well, I've been put on a CGRP antibody. I've been told I have to come off it in a year, because that's the guidelines, and then things might come back. Will it work? Will it still work? And I said, well, the good news is that there's patients now, there's data published now, and the people that have been on this drug now through the trials for, half a decade, 5 years or so, 6 years, and no loss of efficacy. So they're still working. So first, good news is that some of these new drugs, the evidence we've had don't suggest that that's the case. So that's great. STMS, again, that stopped working because the company went bankrupt and you can't get it anymore. That's a pretty clear one, but it's coming back now. And I guess it's about optimal dosing, optimization. I think you've got to look at a situation whereby across your life cycle, there's a lot of events happening and changes. We've focused here on menopause, perimenopause, puberty, but that's not the only thing that happens in your lifestyle. Your work style change, your shift patterns change, and that's likely then going to change your biological response and therapeutics. So we should be looking at the wider picture, what's happening with these therapies. But the good news is that for certainly the antibodies in these therapies so far, for the data, we don't have 20 years, 30 years, we've got 5, 6, 7 years worth of data. They seem to not be wearing off actually, so that's a good response.
Yeah, that's really positive to hear. Thank you. Okay, I think we're just one more, and it's obviously, I think it's a credit to your passion and your speech, but lots of people asking just how they can learn more about your work, how they can get involved, how they can volunteer themselves, all sorts.
So I was reminded that, again, at the break, I spoke to lots of people during the break. I was reminded during the break that one thing to say is there are some blogs on the Migraine Trust website. I think in your most recent newsletter, there is an article where we talk about our work in the Migraine Trust and how they've helped us. So if you pick up a copy of that, if they have it here, or look on the website to see that. But also a little while ago, there's a thing called the Heads Up podcast. That's what it's called, isn't it? Yes, I'm getting nodding at the back. It's called the Heads Up podcast, yes, because we spoke about it. So there's a thing called the Heads Up podcast, which I did with myself and a GP with special interest, Katie Monroe. We just had a chat over Zoom for like an hour and 20 minutes about the science of migraine. And we just meandered our way through the pathway. So if you look at the Heads Up podcast, there's lots on there, from hormones and migraine to cluster headache to everything. But somewhere in there you'll find one where I'm speaking, and maybe if you run it through a computer program, you can get auto cue or something that helps to translate a little bit if you're struggling, and you can get the bits you missed from today.
Perfect. Thank you so much. That's awesome.
Thank you to you guys for coming.
3 quick thank yous. 1 to everyone who's come and spoken today. They've been great. I hope you've learned some things. 2, to the Migraine Trust team for putting on such a great event. And 3, thank you to you who've attended in person and those of you who've attended online. We only exist for patients, that's you. So thank you for coming. We really appreciate it. Have a good evening.